And now it's time to change gears and move to papillary thyroid carcinoma. And to do that, we have today with us Professor Miguel Melo, who is consultant endocrinologist in the Department of Endocrinology, Diabetes and Metabolism of the University Hospital of Coimbra. He is also professor of endocrinology in the Faculty of Medicine of Coimbra and affiliated researcher in the Institute of Pathology and Immunology of the University of Porto, obviously all of them in Portugal. Professor Melo has published 4 book chapters related to thyroid cancer field and diabetes. He has also published around 70 articles in scientific journals such as JCM, Endocrine-Related Cancer, Journal of Endocrinology, etc., and has also an H index of 18. He has a strong expertise in biomarkers of prognosis and treatment selection in differentiated thyroid carcinoma, and also in radioiodine treatment of differentiated thyroid carcinomas. He is a regular speaker at congresses and scientific meetings, including those of the Portuguese Congress of Endocrinology or European Society of Endocrinology meetings, and also the annual meeting of the European Thyroid Association. For all these reasons, it's a pleasure for us to have you here, Professor Melo, and the floor is yours if you are ready to deliver your talk.
Thank you very much, Manuel. Good afternoon to everybody. It's a pleasure for me to be here and to share this session with Professor Rossella ELISEE. It is indeed an honor, and I would like to thank the organizing committee from the European Society of Endocrinology for the kind invitation to me. I will discuss some topics on diagnostic and therapeutic advances in thyroid cancer. I will focus on follicular cell-derived thyroid carcinoma. These are my disclosures, and this is the agenda of my presentation. And after a brief introduction, I will do some short comments on the new WHO classification of thyroid tumors, because I think there are some interesting topics to be discussed. Then I will address some strategies for treatment and follow-up based on risk stratification. And initially, I will concentrate my attention on low risk and very low risk neoplasms. I will discuss where do we stand regarding active surveillance now, and also some minimally invasive procedures. Then I will move to the other side of the clinical spectrum of thyroid cancer, and I will discuss the treatment of advanced carcinomas, thyroid carcinomas, and I will follow a little bit the end of the presentation of Professor Rossella ELISEE, sharing some data on specific inhibitors and also on redifferentiation approaches. So I think that the 2 presentations are complementary. So, brief introduction. We are all aware that the incidence of thyroid cancer has increased in the last 20 years. We also know that we did not see an increase in aggressive variants or in disease-specific mortality. And in fact, 1 in every 4 or 1 in every 5 thyroid carcinomas that are diagnosed today correspond to a very low-risk neoplasm. This is the situation in Portugal. In Portugal, thyroid cancer is the 3rd more frequent tumor in females. And if we combine this epidemiological data with data from autopsy series that show that the prevalence of occult subclinical microcarcinomas is between 10 to 14%, and it is only slightly more frequent in women than in men, and I'm talking about autopsy series, then we can conclude that majority of this increase in incidence can be explained by the overdiagnosis of very low-risk neoplasms, although a small increase due to environmental factors can be happening at the same time. So if we have an epidemic of low-risk neoplasms, then we need a proper classification of thyroid tumors and also a proper risk stratification system. Regarding the recent WHO classification of thyroid neoplasms, I would like to make a brief comment on 2 or 3 points. The first one is the category of NIFT-P. This is now included in the group of low-risk neoplasms that are apart from malignant thyroid neoplasms. And the concept of NIFT-P started about 7 years ago with this proposal to rename the non-invasive encapsulated follicular variant of papillary thyroid carcinoma. And this followed a multicentric international study, retrospective study, that showed that in more than 100 cases of these tumors, treated only with surgery and in the majority of cases with lobectomy, and after a median follow-up of 13 years, no adverse events, namely recurrences or metastases, occurred. So diagnostic criteria were proposed for NIFT-P. This was endorsed at that time since the beginning by the WHO classification, and we start having this diagnosis as a very low-risk neoplasm and apart from the malignant neoplasm category. The introduction of NIFT-P has some implications for clinical practice. The first one is that we would like to identify those lesions before surgery. It's not completely possible, but we should know mainly their imaging characteristics beforehand to try to identify them. So usually an NIFT-P presents as a solid isoechoic nodule with well-defined borders and absence of microcalcifications. And in most cases, it corresponds to a TRADS3 lesion. Another implication is that there was a decrease in the risk of malignancy in the indeterminate categories of Bethesda if NIFT-P is no longer considered a malignant tumor. Several studies showed that the absolute reduction in risk of malignancy is between 2 to 10% in the indeterminate cytologies, and this is now recognized by the Bethesda classification system. In our own institution, the introduction of NIFT-P led to a decrease in 5% of the risk of malignancy in category 3 and 10% in the risk of malignancy in category 5. I must say that this is very heterogeneous. So I think that each institution should have their own data, because it is the only way to make sure that we really know what the risk of malignancy is with all the changes that we had, both in the cytologic classification and also on the histological classification of thyroid lesions. And of course, the ultimate objective of this new category is the minimization of overtreatment. Namely, less total thyroidectomies, less radioiodine treatments, and the decrease of the psychosocial burden of a cancer diagnosis for patients and their relatives. However, several studies show that the risk of recurrence is almost zero, but not zero. And some authors propose a different follow-up for patients that have a NIFT-P that is different from those who have a fully benign diagnosis. This was recognized by the ATA, saying that in some cases, depending on the context, patients could be followed with thyroglobulin and neck ultrasound. I must say that, in my opinion, this depends a lot on the pathology team. If the pathology team follows very strictly the criteria for NIFT-P, I truly think that the risk of recurrence is zero. But if the pathology team does not follow the diagnostic criteria in a very strict way, then 1 or 2 cases with recurrences may happen. Now, moving to the malignant thyroid neoplasm category. We now have follicular thyroid carcinoma, as usual. We have the invasive encapsulated follicular variant papillary thyroid carcinoma that is now a category like follicular thyroid carcinoma. So this is almost like NIFP, but it is an invasive, so it is malignant. We have the oncocytic carcinoma, and of course, we have the most frequent papillary thyroid carcinoma. And there is a difference in denomination. We don't have variants anymore. We have subtypes in this new classification. And for those of you who want to have a closer look, you can see that you can no longer find papillary thyroid microcarcinoma because this is no longer a histological diagnosis in this classification. In the WHO classification, the experts advise the subtyping all papillary thyroid carcinoma irrespective of their size. And of course, this is the right way to do it because it is completely different to have, for instance, a 7 millimeter tall cell PTC from a 7 milliliter classic PTC. However, they also mention that the clinical entity of microcarcinoma is still useful and can be used. And I must say that I fully support this point because it emphasizes the very good prognosis of the majority of these lesions. We also have a new category in the less differentiated, more aggressive tumors. That is this new differentiated high-grade thyroid carcinomas. These are rare tumors, usually large, usually invasive, that arise mostly in elderly patients with frequent distant metastases and that are characterized by the presence of mitosis or necrosis. I think that this is an attempt to standardize classification because some years ago, the pathology team from the Memorial Sloan Kettering Hospital in New York showed that the single presence of high-grade features like mitosis and necrosis was associated with guarded prognosis and could identify a more homogeneous group of tumors. And after that, many papers were published with the denomination poorly differentiated thyroid carcinoma that use these criteria, the presence of mitosis and necrosis, and not the classic Turing criteria for poorly differentiated thyroid carcinoma. These two categories are now apart in the new classification. This is clear, and I think that this will not happen in the future. After the separation, the clear separation for these two categories. Now, moving for treatment and follow-up. If we have many patients that are low risk, of course, we need to do a proper risk stratification and, if possible, using clinical and imaging data from the beginning to identify candidates for minimalistic management. And of course, we also have the first classic time for risk assessment that is immediately after surgery in operated patients when we have both the clinical and the full pathology report. So this is the first time we do a risk stratification. We are now trying to identify patients with very low risk lesions that are candidates for minimalistic management even before surgery, because as we will discuss next in the presentation, some of them may actually not need surgery for their thyroid cancer. And of course, we still identify low risk patients, and I'm going to talk about this. Usually we stratify risk after surgery using the AGCC TMN system for risk of death and the ATA risk system for the risk of recurrent or persistent disease. And as we know, most of people with thyroid cancer do not die, from their cancer, so the risk of recurrence or persistence drives most of our clinical decisions. So what is low-risk thyroid cancer? Low-risk differentiated thyroid cancer has a risk of recurrence of persistent disease of less than 5%. And making this thing short, we are talking about intrathyroidal differentiated thyroid carcinoma, less than 4 centimeters, with less than 5 micrometastases, and that do not have any of these higher risk characteristics like aggressive histology, extrathyroidal extension, vascular invasion, or incomplete resection. So for these tumors up to 4 centimeters intrathyroidal, lobectomy may actually be the treatment of choice. Several studies in last year showed that there was no difference in outcomes when we compared patients that were submitted to lobectomy in comparison with total thyroidectomy. And of course, morbidity is higher with total thyroidectomy. So for these low-risk patients, lobectomy seems a safe procedure. Now, the other choice we have today, especially for very low-risk tumors, is active surveillance. And I will talk mainly of papillary thyroid carcinoma with less than 1 centimeter. The observation of papillary thyroid microcarcinoma started in Japan about 30 years ago. We now have a very long follow-up, and this approach was followed throughout the world, in Europe, like in ESE, in the United States. And we can see that during time, with long follow-up, the increase in size happens in a minority of cases. If we consider the cutoff point of an increase of 3 or more millimeters, we can see that in most cases it's about 5 to 10, 15%, it depends a lot on the follow-up, that patients that will have an increase in size. The Japan data also showed that patients that are younger, especially when they are younger than 40 years, may actually have a more propensity to have an increase in the size of their tumors. But there are the other issues to take into consideration when we see the results of active surveillance in papillary thyroid carcinoma. And they are, of course, the appearance of lymph node metastases, and we can see that during a long-term follow-up, less than 5%, in most of cases 1 or 2% of patients develop lymph node metastases, and we can see that there are no cases of the appearance of distant metastases. It's also good to have to bear in mind that the conversion to surgery happens through time. It depends a lot on the series. You can see that it can go from 5 to 25%, but we must say that in the majority of cases, it was patient's will and not the progression of the tumor that lead to surgery. So in most of the cases, the patients felt insecure or did not want to follow the follow-up protocol anymore and decided to be submitted to surgery. This concept of active surveillance in the last years has been growing and has been expanded to larger tumors. And I can share with you the results of a very preliminary study from the Harvard Medical School, recently published in GCN, showing that in their small series of 69 patients with intrathyroidal PTC, and there is a mix of completely malignant lesions and also of lesions that were included because they have a suspicious molecular test in the AFIRMA gene profiler classification system, with 38% of the patients with nodules with more than 2 centimeters and the results were not that different in comparison with microcarcinoma. Of course, more patients have an increase in size of more than 3 millimeters, 21%. But if we see the results regarding the volume increase of more than 50%, it is about 25%. It is 10 to 20% in microcarcinomas. About 20% of the patients underwent delayed surgery, but there were no cases of disease recurrence. So this is a very preliminary data that shows that at least in smaller tumors, active surveillance can be a safe approach. Of course, we need to select the best patients to do active surveillance, and the ideal patient must have several characteristics. Patient characteristics, for instance, being older, want to accept active surveillance, but also some tumor characteristics. And the best candidates are those who have solitary nodules with well-defined margins, and especially when they are surrounded by more than 2 millimeters normal parenchyma, because this can avoid the possibility of extrathyroidal expansion and damage to the surrounding tissues. I must say that this is very safe when we have the possibility to have a proper ultrasound follow-up, because from the moment the patient is in active surveillance, the thyroid ultrasound is the imaging test that will guide all the follow-up of the patient. Now, just a few words about minimally invasive techniques. There are several studies on thermal ablation, mainly using radiofrequency, microwave, or laser. They seem effective and safe. Of course, that we should take into consideration that some of these lesions could be just submitted to active surveillance and not to a procedure. So I think we need more data to see if these thermal ablation therapies are really useful for the majority of patients with small tumors, or if they can be just used in some of them. Now, moving a little bit from the low-risk categories and moving to the high risk, we know that we are talking about less frequent thyroid carcinomas. I didn't talk about radioactive iodine up till now, but I can sum it up by saying that today, most of low-risk tumors do not have a recommendation, a routine recommendation for treatment with radioiodine. In the high-risk category, all of the patients still have recommendation, and in intermediate risk category, I could say that it is a case-by-case choice and option. Moving for the treatment of advanced radioiodine refractory thyroid cancer. As Professor ESE said just a few minutes ago, we are now changing our approach from these multi-kinase inhibitors that had mostly an anti-vascular effect from target inhibitors. And we know that we can use several of these target inhibitors in thyroid cancer, but we must know, of course, what is the molecular alteration that tumors have, usually, but not always, the driver mutation, to choose the drug to use. And if you look at this, Professor ESE talked about RET inhibitors. I'm not going to talk about them. I'm going to talk about TRK inhibitors and also BRAF and MEK inhibitors. You can see that many of them also have the ability to restore the expression of thyroid differentiation genes. And this is why Professor ESE showed a few minutes ago that using this agent, there was the possibility to restore radioiodine uptake. So, concentrating my attention in differentiated thyroid carcinoma and also in anaplastic thyroid carcinoma, we now have the possibility to have, apart from RET inhibitors, TRK inhibitors when tumors harbor a rearrangement involving this gene. We also can use a BRAF inhibitor, namely dabrafenib, and the combination of dabrafenib and trametinib, which is a MEK inhibitor, and this is especially effective in BRAF mutated anaplastic thyroid carcinoma. Just to share with you some data, and this is, I would say, quite similar to what we saw with selpercatinib in RET mutated tumors. We can see that we have an overall response that is quite good, about 70%. This is, of course, a very small series in comparison with the selpercatinib study. This is a preliminary study. This is the waterfall plot. You can see that most of the patients do have a response. And as Professor Elise said, we do have a huge difference in the side effect profile with these new agents in comparison with multi-kinase inhibitors. And especially when we look at grade 3 and grade 4 adverse events, we can see that there are few events in most of the patients. Having a look at BRAF inhibitors, they were quite promising at beginning in differentiated thyroid carcinoma. I'm talking about BRAF mutated PTC. Unfortunately, expectations fall a bit short because we can see that we had partial response in this study that compared dabrafenib and dabrafenib plus trametinib, the association of both, in BRAF mutated differentiated thyroid cancer, and you can see that partial response was obtained in 30 to 35% of the cases, and apparently there was no benefit of adding trametinib to dabrafenib. I can say that this is completely different from the results we have today in BRAF mutated anaplastic thyroid cancer. These are some data with this association in BRAF mutated ATC, and we can see that when we compare this with the results we had with the classic therapies, there is a huge difference, for instance, with the median overall survival above 1 year. And I think this is very, very easy to see in a recent paper here from our colleagues from the Portuguese Cancer Institute in Lisbon, when they compared compassionate care with multimodal treatment, surgery, radiotherapy, chemotherapy, with the use of dabrafenib and trametinib in BRAF mutated anaplastic thyroid cancer. And you can see that the survival since diagnosis is completely different. We can see the Kaplan-Meier curves here. This one is very light, so it is difficult to see. This is the compassionate care. And you can see that the overall survival, we can see that it can goes from 40 days in compassionate care, 156 days in multimodal treatment, and almost 500 days in the group of patients treated with the association. Now, a few words about redifferentiation strategies. This is a very old expectation in thyroid cancer, but it came to light once again about 10 years ago with this paper, also from the Memorial Hospital team, that showed that using selumetinib, a MEK inhibitor, it was possible to increase radioiodine uptake, and some of the patients had a confirmed response to the new radioiodine treatment. We can see that now many other agents are able to reinduce radioiodine uptake. This is an example with larotrectinib, a TRK inhibitor. And this approach was performed in some small series using all these agents. We can see that we have partial responses that can go from 10% to 40%. So these are promising, but we still need further data with each of these agents And with each of these protocols, because protocols in this study are quite different, and the differences in protocol may justify some of the outcome differences. But I must stress that the most important study in the redifferentiation strategy that was published in the last years was this one, the MEDAIOT study, that assessed the use of dabrafenib and trametinib as a redifferentiation strategy in BRAF mutated differentiated thyroid cancer, and the single use of trametinib in RAS mutated differentiated thyroid cancer. Please bear in mind that dabrafenib is a BRAF specific inhibitor, so it does not make sense to use this in RAS mutated tumors. These were the main results. This is for BRAF mutated DTC. We can see that some of the patients' radioiodine uptake was restored, and from baseline we can go from 4.8% till 95% in the post-therapy whole-body scan. So it worked as a redifferentiation strategy. Now, looking at the objective response rates, we can see that in the first months, it seems quite promising, with up to 50% of patients showing an objective response. But with time, the response rate seems a little bit lower. There are several explanations for this, and we should also consider that the single use of the agents may have a clinical strong impact. And so we can discuss this at the beginning. It can be the radioiodine, it can be the drugs, it can be the effect of both combined, but it is sometimes difficult to separate the effect of them, especially in the short-term follow-up. This is the waterfall plot for this study. We can see an overall response rate of 38%, which is quite good, I should say. Now in RAS mutated tumors with trametinib, we can see that radioiodine uptake was indeed reduced in 2 in every 3 cases of radioiodine resistant RAS mutated tumors, but the objective response rate was lower, with numbers up to 20%. Now, to finish up, I would like to say that we know that the incidence of differentiated thyroid carcinoma is rising, mainly due to the existence of a large reservoir of subclinical neoplasms that are now being detected with imaging procedures. The new WHO classification introduces new categories, these low-risk neoplasms, and also the differentiated high-grade thyroid carcinoma. And I think those are the most relevant changes since the last document. We know today that risk stratification is of utmost relevance to guide our decisions on treatment and follow-up. We must avoid overtreatment, and we should concentrate our treatment and follow-up, more intensive treatment and follow-up, in the higher risk patients. The minimalistic approaches seems a good option to take into consideration, like active surveillance for low-risk differentiated thyroid cancer, especially, of course, when patients have many comorbidities. And on the other end of the clinical spectrum, we are fortunate to have new advances, namely new treatment options like specific inhibitors, and we also are very thrilled with this new redifferentiation data. And I would like to thank you for your kind attention.
So thank you so much, Professor Melo, for also this great talk and this magnificent overview of the plethora of therapeutic approaches that we have. That together with the talk of Professor ESE, I think that we could have a great overview of where we are now in the treatment of this kind of tumors. So just a message for all the people that is connected to this seminar. Remember that you can send question to both Professor ESE and Professor Melo through the question and answer button that is below the screen. You can check it there and send the question and discuss with them anything that they have been presented during the talks. I would like to again thank you for your time, for having the time to prepare this presentation for us and sharing these results. And while the audience start sending questions, I would like to also ask you a couple of things. I think your both talks were very interesting. I think this is a new era in the treatment of not just thyroid, but also other tumors. Indeed, yes, Professor ESE mentioned that the clinical trial with RET inhibitors were not just basically focusing thyroid cancer, but other kind of tumors. So I think this open new avenues in the treatment of tumors in general, not also thyroid. I was quite surprised, Professor Melo, because of the data that you presented with the incidence of the thyroid tumors in females in Portugal, right? This is different to the incidence compared with other countries, I guess, or is something that is common to the Mediterranean or European countries?
Well, I think that what happens in Portugal is that it is a bit higher expression of what is happening in the Western world. I must say that we do have a very good pathology team here in Portugal that has a network throughout the country. And I think that maybe 20 or 30 years ago, they started their joint sessions that happen every month. And people, pathologists, start being very keen imaging all the thyroid glands when they were resected from patients. And I think this is one explanation for the higher incidence in Portugal than in other countries. I must say that, for instance, we do have a gradient from north to south, and the incidence is higher in the north and is lower in the center of the country and in south. And the Institute of Pathology, the Patimulp, is in the north, and of course there's some regional issues there. So I believe this is one of the explanations. The second explanation is that in Portugal it is very frequent for females to have a thyroid ultrasound for whatever reason. And these are not asked or prescribed by endocrinologists. Most of the cases, they are asked by gynecologists or GPs, and then they find a small nodule, and then the investigation starts, and many times it leads to diagnosis of a low risk or very low risk thyroid neoplasm. So this is the same in, I think, in every country. It depends a lot on how people can assess thyroid ultrasound. If they have easy access, more lesions are diagnosed, and also the pathologists also have a role there, because if they are going to go through all the thyroid and look very careful, many times they found an incidental microcarcinoma.
Okay, yeah, totally understandable. So we have some question from the audience. There is a question sent that is saying, can you tell us more about the anti-CEA therapy and why we use them? So I don't know if any of you want to take this question.
I'm sorry, because I did not.
Anti-CEA.
CEA therapies, correct?
Yeah.
Well, this was something that was done in the past. There was a radio-labeled therapy by using the CEA, because medullary thyroid cancer is a great producer of CEA. So the methodology was based on the use of antibodies radio-labeled against CEA. But indeed, the results have never been very relevant, and nowadays this kind of therapy is not more performed, at least not in Italy.
Okay. There is also a general question regarding the choice of first-line therapies. The question is, in your centers, are you choosing target or multi-kinase inhibitors as first-line therapy in patients with somatic targetable alterations?
If the question is for me, probably also for Miguel, I think there are some differences in different countries because, for example, larotrectinib, that is an anti-TRAC, in Italy is prescribable as a first line in patients with TRAC alterations, while selpercatinib so far is can be prescribed as first line but is not reimbursed. So the cost is too elevated, and because it can be prescribed as a second line, in this case is reimbursed, we usually start with the multikinase inhibitors, the standard therapy, let's say lenvatinib in radiorefractory differentiated thyroid cancer and vandetanib or cabozantinib in medullary. And then at the time of progression, we can move to selpercatinib and it is reimbursed. I don't know if in Portugal is the same or is different.
It's very similar, Professor. Actually, in most cases, we still use multikinase inhibitors due to reimbursement. And this is not a situation that is homogeneous in all the country. We have some hospitals that are able to deal with the prescription of a selective inhibitor from the beginning, and they support the use of the drug in this line, but in most of the cases they are used as second line due to reimbursement issues.
Exactly.
And it's the same in my hospital.
Okay, great. There is also a couple of questions related to non-invasive follicular thyroid tumors. One question is there a maximum tumor size for that non-follicular tumors diagnosis cannot be given with confidence?
First, I would like to thank for the question. This is very important because on one hand, we do have now data showing that up to 4 centimeters, it seems to be safe to have this diagnosis and to consider this as a very low risk neoplasm. But on the other hand, I must say that it is a hard work for pathologists to go through a 4 centimeter lesion and make sure that it is a NIFT-P. So I had the opportunity to look at our own data in my institution and also to literature and data from other countries. And my personal perspective is that although it's safe, it's not being used. I think that the diagnosis of large lesions as NIFT-P are seldom performed. So I think that many lesions that would fulfill the criteria for NIFT-P, if they are very large, sometimes pathologists don't give that diagnosis. But we do have data if the diagnosis is performed in the proper way, that it is safe to consider them as a very low risk neoplasm.
And the second question related to that after the diagnosis is, any of those tumors require treatment?
Well, we don't know. This is the truth. We believe that this is my personal belief, they do not need, if we need for treatment, I think people are talking about surgery. So the problem is that we are not sure that it is a NIFT without surgery. And this is why we are now moving for case-by-case selection for active surveillance, and we are expanding a little bit the concept of active surveillance, because we know that we know some of the imaging characteristics of NIFT-P. We know these are very low-risk neoplasms, and in some cases, people with indeterminate cytologies that may correspond to a NIFT-P lesion are being followed. And I believe that this happens everywhere.
Okay.
Yeah, if I can, I would support what Miguel is saying. Well, first of all, once the NIFT-P has been removed and the diagnosis is certain, I think we have to consider as we consider the follicular adenoma. It happens sometimes that after years from the diagnosis of follicular adenomas, we can have cases with distant metastasis. It can happen, but they are very rare. Similarly, the similar things is for NIFT-P. Is a kind of follicular adenoma. Then it can happen that in 10 years, 20 years, one out of, I don't know, 200, 300 can develop some metastasis. However, I agree with Miguel that the size is important, because if the NIFT-P has a relatively small size, the pathologist is much more able to perform a right diagnosis of NIFT-P, because he can look at the entire capsule. The biggest is the size, the more difficult is the diagnosis.
Okay, okay. Okay, there is another question that I rescued from the chat to the question and answer, and this is for you, Professor ESE. The question is, hi, I would like to ask a specific question regarding papillary thyroid cancer diagnosis during pregnancy. I will like pregnancy and one subclavicular lymph node involved. MRI neck confirmed only one lymph node affected. Is monitoring till delivery an option, or would you recommend surgery?
No, I would say that I would recommend the lady to have her pregnancy and then come back at the end of the pregnancy. We can perform a new neck ultrasound, or even during pregnancy, we can monitor with neck ultrasound. But for sure, the surgical treatment, unless there is a very rapid progression of the disease, can be postponed to the delivery.
Yeah, fully agree. I must say that I fully agree. We have some cases, and it is what we do. We just look at it during pregnancy, and then patients are submitted to surgery after delivery.
Okay. The next is very, very short question. Why combine dabrafenib plus trametinib treatment? Why this combination?
The combination is because it was shown that the double inhibition of this pathway will have better clinical results. And also, this is from the clinical standpoint. If we look at the response, and it is not only in BRAF mutated thyroid cancer, also in other models and other tumors that are BRAF mutation, this was demonstrated. And also, some preliminary data also shown that the ability to express differentiation genes in thyroid cancer harboring BRAF mutation is higher using both drugs. So even in the redifferentiation strategy, it can make sense.
And if I can, I agree, there is also some evidences showing that by using only dabrafenib, the MEK pathway can increase, the tumor try to escape, and increase the MEK pathway. And trametinib can block the MEK pathway, so there is a kind of combined action on different pathways.
Okay, this links perfectly with the next question that was sent by Ana Paula Barbosa. Thanks for the excellent presentation. What are the indications for molecular studies of the tumor, and which kind of panel is used? Do you choose?
Well, I can start and then Miguel can add something. Well, this is a very relevant question. When to perform molecular analysis? I would say for sure in medullary thyroid cancer, when you have distant metastasis, because you know that sooner or later these patients will require a systemic therapy. If you want to wait a little bit, you can wait until the evidence of disease progression. But at the evidence of disease progression, the molecular analysis should be performed. The problem to postpone too much the molecular analysis is related to the, let's say, the long time that can be respect to the surgery, and the tissues maybe cannot be found, or even if they are found, they are too old and nucleic acid are not more adapted for the analysis. So in other words, in any case of advanced thyroid cancer nowadays would be useful to have a map of the genetic alterations. Miguel, if you want to answer about the type of analysis.
Yeah, I fully agree. We are now doing it when we face an advanced progressive disease, sometimes from the beginning, because we know that the choice of an agent will happen sooner or later. I think that today we should have a study by next generation sequencing that, of course, encompasses all these possible targets. Every mutation or genetic alteration that is targetable should be included in the study.
Yeah, there is one last question that I think is also very interesting is, are all mutations you refer in your talk somatic? Does the target therapy differ if the mutation is somatic or germline? Or is the treatment the same?
Absolutely not. The germline mutation, cases with germline mutation and cases with somatic mutation, of course we are talking about medullary thyroid cancer, are very good responders to selpercatinib in both cases. There are no differences.
Okay. So, well, I think we have covered all the questions from the audience. We are indeed really close to the end of the session. So I think it's time to close this session. Thanking you again for the great presentations, for the discussion, for having time to be here with us and answer all the questions for the audience. I would like to say that we had a high number of attendees. So congratulations, because of the topic was for interest for the European Society members. So thank you again for participating here. And I just would like to remind that we have still 2 more Spotlight on Science to be present during the year. We will have a gap during the summer, but we will be back in September. We will be talking about hyper and hypocalcemia in September, and then we will have a final spotlight on science on November about metabolic dysfunction associated steatotic liver disease. So I hope see you again in those spotlights. I would like to wish you a good summer and have some time off and rest a little bit. Thank you again for being here today. Thank you, Professor ESE. Thank you, Professor Melo, for your time. I hope to see you soon. Thank you so much, and bye-bye.
Thank you.
Bye,
Bye.
bye, bye. Thank you,
Bye.
bye.